Many of you were at this retreat, so it was held on June the 24th. We had 34 participants from across the city. And I think we had quite a good, I was very pleased with the cross-section. So we had 18 people who I'd classify as basic science, imaging, physics. We had 12 clinical colleagues, either clinician scientists or clinical researchers. 3 people, research coordinators, so that's come up a couple times during the day, and we are lucky enough in London to have a couple team grants who already have coordinators, and actually I classify Sandra Kleinsteiber organized this in that capacity, as well as Paul O'Brien. And I think the addition of this type of person to our community is wonderful. And then we also had participation from the London Health Sciences Foundation. I know there's some foundation members here today, which is great. So the goals of the June retreat were a little different. So as Glenn said, it was kind of a grassroots thing, and really it was more centered around the science and what was going on right now, as well as some new opportunities. So we had a really wonderful overview of the current translational programs that are going on in the city, in particular focused on the 4 research teams in breast, prostate, head and neck, and ovarian cancer, and what they have been doing both from a research perspective as well as a training and organizational perspective. As well, one of the sort of driving forces behind the June retreat was that there are really a number of exciting new initiatives in London coming from different areas. So, for example, the opening of the Baines Center, the successful OICR translational team grant that Eric Winquist headed up, as well as obviously the Center for Translational Cancer Research. So these are all new opportunities combined with major changes in leadership at the hospital, at Schulich and at Western, that really, I think, provide a great opportunity for cancer to move to the next step in the city. And also, importantly, it provided an opportunity after we got all this information to have a very open and frank conversation with some breakout sessions and brainstorming. And so the result of these brainstorming sessions were really a set of recommendations. So what we did is at the retreat, we had we recorded the retreat, and Sandra and Paul very kindly put together some minutes, and we generated a report. And out of this report, identified some key recommendations and action items that I'll explain in a minute. This was presented to the CTCR Management Committee for discussion and sort of further refinement of the recommendations. It was then also distributed to everyone who attended the retreat, as well as everyone who was on the initial invitation list, which was covered Western and LRCP. And hopefully some of you, or people that received it, have had a chance to read it, or at least read the sort of summary of recommendations. If you didn't have a chance to look at it and you'd like it, then Sandra has, you have some here. You have the key recommendations, and we can also send you the full report, which is about 15 pages long. So then over the past, I guess, month or so, Glenn and Sandra and I have also met with leaders of the key stakeholders. So we talked to Brian Orr, we talked to David Hill, and we talked to Victor Hahn, and really sat down, went through the recommendations, and had some really good interactions in terms of the action items and what's being done. In many cases, there was already some initiatives underway that would help address our recommendations that we weren't aware of. And in other cases, it sort of really provided a forum for discussion and further brainstorming. And then we ended up here today. So I'm excited as the afternoon went on to sort of realize that everything that Lynn and Anthony identified, as well as things that Dr. Strong and Dr. Hill and Dr. Hudson touched on earlier, we really have incorporated into the key recommendations and have started, I think, even this early to move forward on some action items. So the first recommendation, not surprisingly, is related to funding. And key factors are really this underlying infrastructure. So obviously funding for ongoing operating grants are important, but we also need to fund some of the key bricks and mortar that are still a little shaky. And so there's been the comment about the hospital institute scientists and finding sort of more sustainable funding and career planning for them. As well is, and it was mentioned a couple times, is this idea of protected time for clinician researchers. And it's very difficult in a publicly funded healthcare system, and Dr. Hudson said, in Canada we don't do this very well, even though we say this is the persona that we want. So I think that, it would be great to be able to address this at a national level. In the meantime, hopefully we can address it at a local level. And then, of course, funding for small grants and bridge funding, especially in the current funding climate. There was the comment that the gap funding program through Schulich would be increased so that you can run a lab, in between getting your CIHR grant, sort of in the different competitions. So the key action item is really at the local level, engagement and collaboration of the key stakeholders and their related foundations in order to work together towards this goal. So I think this is particularly important because the hospital, at the foundation level, the hospital foundations and the university foundations can raise money. They have different mandates and different abilities to raise money for specific purposes, most of which are complementary to each other. So I think in order to move forward, it's really important that they're not working against each other, but working together to do this. And Lawson obviously is a key stakeholder in this. And because it's an academic center, the hospital scientists are, we're all integrated into the academic mission. And so if the stakeholders can work together to come up with solutions for things like protected time and career planning, then it will make the city stronger as a whole. The second recommendation is to develop citywide enablers of translational cancer research. And several times during the retreat from different groups, and Anthony's mentioned this already, is the challenges around pathology and research ethics in getting clinical research done. And so developing easier ways to do this would facilitate translational research. And I understand through our discussions with the leadership that there are some issues some things being addressed both locally and potentially at the CIHR level that would help facilitate things on the ethics side. And pathology, the hope would be that we can engage more of the pathologists, that pathology might be able to hire some new pathologists that have a research focus, and that agencies such as OICR and their new transformative pathology stream will help facilitate this as well. Again, as Anthony mentioned, more robust clinical outcome databases. There are a couple good examples. So Muriel Brackstone has already established, in a fairly short time, started to establish a breast database, but if we could do that across disease sites, then that would be a major facilitator of translational research. And again, as it's come up again and again, this assistance with grant facilitation and commercialization. So back again to the key stakeholders and engagement of them, and in particular in this case, the research offices, because there are, Lawson has a business office that can help with interactions with industry, and I don't know if, citywide, how many investigators are using that. If Schulich's expanding their research office, then perhaps this would be a great area to sort of flag on their radar as being important for this, the new staff and the new enhanced capacity that they hope to have. So sort of, again, this message of, everyone in the city needs to work together to move forward. So the third recommendation was to enhance and formalize linkages between the existing sort of core translational research groups that already exist. So this includes the Lawson Translational Cancer Research Team, which is funded by the High Impact Clinical Trials Program through OICR and headed up by Eric Winquist. the translational research teams that I mentioned, as well as the citywide clinical disease site teams, of which there are, I believe, 11, each focused on a specific. And some of these disease site teams already have quite a strong research component, but many of them do not. So if we can enhance these linkages, that will hopefully increase that. So action items that we discussed. So this is an idea that has sort of evolved actually as we have been discussing the recommendations with the leadership. And the first recommendation is the establishment of regular CME recognized interactive meetings, potentially called translational rounds. So we have grand rounds, we have breast rounds, we have prostate rounds, et cetera. So this would be a translational rounds facilitated by the CTCR, but driven by the clinical side. So on the basic science side, we already have a wonderful initiative in the IND seminars that's organized by Gabe DiMattia and driven largely from the basic science side. And this provides a forum for interaction between clinicians and scientists when we sort of learn about different drugs and the basic science behind them, and then the clinical trials that are going on in terms of targeted therapies. But the idea behind the translational rounds is that, and I think it was Brian that suggested that if it was driven from the clinical side, it could become a common mandate between the clinical disease site teams that they needed to present an idea at these translational rounds at least once a year, because there's 11 teams, there's 12 months. And so as an example, say the breast team was going to present, and Ted and I have been talking about this idea. He's gotten some results back from a clinical trial that are sort of intriguing in that there's an interaction between estrogen therapies and targeted therapies that was unexpected, and it merits perhaps somehow going back to the bench to figure out what's going on. But he might not know who's doing what that would help address this clinic. So in these translational rounds, he would get up, talk for 15 minutes saying, here's this really cool thing I've seen in the clinic. I have no idea what it means. It means our therapies are not working the way we want them to. Let's talk for the next 45 minutes in an open forum about how, we could solve that, in sort of a backwards way. And what it would force us to do is maybe if the breast team had to present in March and the prostate team had to present in April, it would also force the disease site teams to get together, think about a research problem, and present it. So we think that it would have sort of impact at multiple levels. And so then this would obviously, if it was a common mandate among all disease site teams, it would bring in, we have the 4 that have research areas already, but it would be great if all 11 did. And I think this would sort of be an initial starting point to kind of get that going. And also a really important point to speak to Lynn's comment is that right now, a lot of this is at the LRCP, and it's really important because there's people all over the city doing work in different areas, some of which they haven't connected up with a disease site team, even though their research clearly aligns with it. So it will be very important in addressing this recommendation that it's a citywide initiative and not just an LRCP initiative. And then the last major recommendation was this idea, this obviously all-important idea of enhancing interdisciplinary collaborations and identifying and supporting novel initiatives to enhance translational cancer research. And we really think that if this is driven, because people's time is very limited, but we spend a lot of time with our trainees, and if this is driven by involvement with trainee programs and enhancement of trainee programs, this might be a potential way to move this forward. So an example is more involvement of basic scientists in clinical research training, several opportunities including the MD PhD program, the summer research training program for the undergraduate medical students, as well as training of clinical fellows. And certainly there's individual labs that exist in the city that already participate in these initiatives, but if we could get a broader participation, this would get back to Lynn's comment about kind of integrating translational research into our trainees sort of right from the get-go. Another suggested action item was to increase cross-appointment of clinicians to basic science departments in order to allow them to supervise, co-supervise graduate students, or even just sit on their graduate committees. So this has worked very well in my lab. I have a PhD student who's co-supervised by Tracy Sexton, a radiation oncologist, and it's certainly enhanced the students' training, and it's also significantly enhanced my understanding of clinical issues and sort of my perspective. And it's an easy thing to do. As well, as Anthony mentioned, really strategic recruitment and strategic hiring, so identifying areas of need, as well as areas, positions that could be filled to complement the existing strengths. And then finally, as a specific example, someone suggested the idea of developing a unique translational research fellow program where you would have to come forward with a project that had one clinical fellow and one postdoctoral research fellow that would be funded to work jointly on the same translational project. And someone commented this is sort of the cheaper version of the clinician scientist because you get two minds, you kind of have this hybrid, and you don't have to pay an infrastructure, a long-term salary commitment, but you get high-level trainees contributing to a translational project. And additional recommendations were to develop communication tools to disseminate translational research opportunities, to formalize processes for existing and new disease-based research teams. So the idea of kind of establishing terms of reference that were somewhat, each team would need to have a set of terms of reference, membership across the city, forums for meeting more formally, things like that. And this would apply not only to new teams that wanted to be formed, but also existing teams. And ultimately, the Center for Translational Cancer Research really will play a key role in enabling all of these goals. And, as Glenn has said, already has plans to do that in coordinating really connections between all of these different groups and stakeholders. So really, I think, we've heard it, and hopefully everyone believes it. Cancer research, I believe, is a citywide strength in London. Our collaborative nature gives us an advantage over some of our bigger centers. And the recent new initiatives, as well as the new changes in leadership over the last year and a half or so, I think provide a real opportunity for us to do something and move forward. And of course, we already have many existing translational research strengths, including, funded team grants, a fantastic pilot grant funding and training grant funding programs, as well as nationally and internationally recognized strengths in areas, that are important for moving forward: imaging, personalized medicine, circulating tumor cells, biology strengths in things like epigenetics and metastasis. So I believe that we're very well positioned to sort of go to the next step.